okay, you have to elaborate on the differential diagnosis. Of course, number one in your differential diagnosis will be will we have we're thinking about preterm pre-labor rupture of membrane. Okay, so when you answer this question, I think what I will do is I will just list the important thing. For example, like she's 32 weeks, she presented to obstetric day unit, and she presents with watery vaginal discharge. But at examination, nothing significant. Probably the uterus is slightly smaller than this, but still quite acceptable in the third trimester, plus minus 3 centimeters. So top in the list, the diagnosis is be a preterm pre-labor rupture of membrane because of the information that we have that she has watery vaginal discharge, which is consistent with Lycor volume. An amniotic fluid index of 6 centimeters at 32 weeks is considered low for 32 weeks. All right, so but we only have one ultrasound scan, so you can comment on that. Okay. Symphysis fundi is smallish, but still acceptable clinically, about 3 centimeters. So the diagnosis for this, the diagnosis will be if you do a speculum examination and you see the pooling of Lycor, that will be a diagnostic and no further testing is needed. And we also should think about the other differentials. All right, okay. Just now we discussed about possibility of preterm pre-labor rupture of membrane because the nature of discharge, the nature of that watery or gush of fluid, and the uterus is slightly smaller, and the AFI for the ultrasound is 6 centimeters. So top number one is likely is preterm pre-labor rupture of membrane. Good. What about PV discharge? If one of the differential is PV discharge, can it be different per vaginal discharge? So on our discussion, we said, okay, usually per vaginal discharge is not watery, maybe more of occasional, or she may have a history of having per vaginal discharge before, unless it is a bacterial vaginosis, which the Lycor the discharge will be very watery, and also clear, and it's also non-foul smelling. Unlike to be candidiasis, because candidiasis usually is curd-like, thicker, could be yellowish, and the vagina, if you see the vagina or the perineum will appear very inflamed. Okay, so when you discuss, you should discuss about around this thing, the area. Unlikely, you can also say, unlikely to be an isolated oligohydramnios, because you have to exclude other causes first. And then you also say that, in your discussion just now, just what was given to you. Okay, that gush watery fluid, uterus slightly smaller than they say 5, about 6. But could it be other possible causes? You said that, we don't have further details in the history. Okay, I would like, it's good if the previous history is, in the history, if you get the history, anomaly scan is normal. Okay, unlikely, renal agenesis, because renal agenesis we usually like in the third N-hydramnios rather than oligohydramnios. And PPRN is the commonest. Okay, and then if let's say you say there's no pooling of Lycor in the posterior fornix, then there are ways to test it. All right, if she doesn't have contractions. Okay, so that can be also in the discussion of your differential diagnosis. Okay, if you test it with now you have significantly you can test with all these new methods rather than testing for acidity or alkaline. You can use what you call that, the insulin-like growth factor binding protein or the placenta alpha microglobulins. You can test that if there's no pooling of Lycor. All right, and now, after the discussion about the differential diagnosis, I wouldn't put, UGR or fetal growth restriction as my differential diagnosis. I know that in the answer script, many of you all put fetal growth restriction as the differential diagnosis. Because one is, 2 kilograms for 32 weeks is fairly okay, all right, even though the life volume is about 6, all right. Of course, we're thinking about, you can, probably the bottom list, like put fetal growth restriction cannot be ruled out, maybe can, but not as the main thing as for the differential diagnosis. Or in the discussion, you probably get marks, not much, saying that, with that life volume, amniotic fluid index, the first one to be shown if you have an early fetal growth restriction, the Doppler is normal. Severely, as you said that, I know some people say like normal Doppler association, that kind of thing. So I will leave that as among the last, not as the main thing for the differential diagnosis. Then the next question is justify further management. Okay. When you've already discussed your differential diagnosis, main thing you're thinking about is PPROM. Okay. So what would you do? Just imagine what you do when you see this patient in the clinic. She is actually being seen in the daycare. So of course you have to manage her as inpatient. Alright? Even though other possibility is bacterial vaginosis or vaginitis or cervicitis, but still you have to rule out PPROM. You have to manage her as PPROM. So inpatient management. Why inpatient management? Justify for observation, okay, for diagnostic purposes. If it's you don't see fully liqua, you can put her on PET charting. You can observe for vital signs, because if she has ruptured membrane, you want to monitor her BP, pulse rate, and you might look for signs and also symptoms of chorioamnionitis. You will send blood investigation basic, okay, full blood count, CRP, of course you will take swab, and that is to be traced. You will initiate antibiotics, and as a baseline, why I say as a baseline, let's say during the admission, she developed symptoms or she continued to leak, it's confirmed by the PET charting is wet and so on. So you can repeat. You said that is monitoring. You will do it, then repeat. Full blood count, C-reactive protein. Initiate antibiotics, yes, all right, because you do not want to, come to a diagnosis later when she already developed chorioamnionitis. Broad spectrum, and what we normally use is erythromycin, 250 milligrams, QID for about 10 days. This has been shown to prolong the pregnancy, because she's only 32 weeks, hopefully, because every single day, the fetus in vitro, provided is no infection, okay, it improves on the perinatal outcome. It reduces the risk of infection also with the antibiotics treatment. What about giving steroids? What's the role of antenatal steroids? So you need to discuss this. You justify, would you take or not? Okay, it's 32 weeks. I think I will give if she doesn't have a full-blown sepsis, all right? Because you anticipate premature delivery if she continues to leak, if it's a 4-water leak, okay, she might go into labor soon. It's a high water leak, probably it will stop. Okay, so with antibiotics, with corticosteroids, it will improve on the perinatal outcome. What about magnesium sulfate? Okay, we know generally, you say magnesium sulfate offers and is good for neuroprotection, but these are mainly for fetuses who are 30 weeks and below, to be good, But she's about 32 weeks, so it's a gray area. So would you start or not start? Okay, if you choose to say that I will give magnesium sulfate, say even though the neuroprotection is clearly good for less than 32 weeks, but there are also some studies shows that under 32 weeks it does also protect, works for neuroprotection. And on top of that, it's saying that if she is not in labor, okay, she doesn't have contractions, okay, and are we thinking, what about the advantages of this? We're thinking about just now what we're saying, conservative management, wait and see, but we anticipate by giving steroid, recovering with antibiotics, monitoring for signs and symptoms of chorioamnionitis versus active management. The active management meaning delivery. at 32 weeks. Okay, there are a lot more of possible complications to the fetus. All right. So discuss about this conservative versus active management. And the monitoring, we continue to monitor, a lot of things to monitor, the bloods, vital signs, symptoms and signs, and also discuss about timing and the mode of delivery. Okay, let's say now, we said that, we will manage her conservatively, and if she doesn't develop contractions, continue to monitor her BP, pulse rate, monitor for signs, symptoms and signs of chorioamnionitis. When would you deliver her now? Okay, of course, if she leaks at about 32 weeks, can develop chorioamnionitis, we aim for 37 weeks. Okay, and what's the mode of delivery? Initially was given as breech presentation.
Oh, great.
Okay, let's say if persistent breech presentation, then the mode of delivery will be by elective cesarean section. Because we anticipate the lipo volume to be reduced, it might be difficult to turn the fetus, all right? But you can also discuss, let's say, after admission, okay, no more leaking liqua, okay, and her vital signs remain stable, no signs of chorioamnionitis, likelihood is high mortality, which has already, the membrane has already fuse, and you can manage her as outpatient then with again weekly monitoring, and assess her again when nearer to term, and that is if the fetus turn into cephalic presentation. So that's how I would approach this CPC lah. Okay, then the next would be on the